I'm Claire Brindis, and on behalf and along with Dan Grossman and our co-sponsors, including the Center of Excellence in Women's Health, it's really a pure honor to welcome you and our distinguished guests to today's event. There was tremendous interest, as you can see, and we had to change the venue just to be able to accommodate, and we're thrilled that you're here. As one of the co-sponsors of the event at the Philip R. Lee Institute for Health Policy Studies, I honor the commitment of the University of California, San Francisco to its research, training, and service missions, and that the faculty and staff of the Bixby Center for Global Reproductive Health and ANSIRH have had a very long history and tradition of conducting groundbreaking research and analysis in the fields of contraceptive development, evaluations of reproductive health programs, research, care, and training in the area of abortion, as well as service throughout the world. So this event really provides an opportunity to discuss the evidence and the research in anticipating the role of California in the future, with the possibility of whether Roe v. Wade be undermined or overturned. In whatever way, there will be a lot of action at the state level. And before we begin our panels, I wanted to just spend a couple of minutes providing some contextualizing about this overall environment in which we're living and in which this afternoon's conversation takes place. First, we need to recognize that tremendous attacks on women's access to abortion care mirrors repeated, concurrent, synergistic, and relentless attempts to dismantle women's access to birth control. And there are many efforts to link contraceptives to types of abortion. The targets of these efforts are women, often women of color, often the poorest of the women among us, and the most marginalized populations. We see this in the effort to dismantle the Title X program, including earlier efforts to eliminate the whole program in the president's budget. But more recently, the attempt to silence providers, undermining patient and provider relationships, and preventing them from providing time-sensitive information critical to women's decision-making. Without our current legal challenges and litigation, providers would have to choose between violating their medical ethics and turning down funding that allows them to serve patients who need quality reproductive health. And obviously, we need to recognize that the efforts at domestic gag rule is also mirrored in the efforts to do a gag rule internationally and globally. Secondly, there's been numerous attempts to limit access to women's health care through numerous efforts to repeal and replace the Affordable Care Act. And as part of those initial efforts, some of you may remember a couple of years ago, there was efforts to totally eliminate Planned Parenthood from being able to provide care. And even though now we feel that at first glance the ACA was maintained, we need to recognize all the threats that remain to the program. There's the reductions in funding for the program overall, threats to eliminating the essential benefits that include access to preventive health visits for women and access to contraceptives without copay, the elimination of tax penalties for individuals who do not sign up for health insurance coverage, which is so key to assuring that a sufficient number of healthy families and healthy people are enrolled in the program, the significant reductions in the funding for community and outreach workers who are so important in navigating for many, many individuals opportunities for getting health care coverage, including many women who do not know about the program without community promotoras and others really reaching out to them. And then eliminating a number of other cost insurance aspects to it. There's also been a number of efforts, and I won't be able to enumerate them all for you, in terms of sanctioning discriminatory practices that would allow employers greater latitude in their ability to exclude contraception from employer-sponsored coverage owing to either their religious or moral objectives, or regulations that would enable conscious clauses or refusal of care for those individuals who object to providing some of the services that we care about so deeply based upon their own religious beliefs. But we're finding now that there's a dismantling or efforts at dismantling protections against discrimination, whether it be in the area of housing, whether it be in the area of the U.S. military, whether it be bans the enlistment of transgender individuals, or a number of other areas. What's very clear is that place matters. Living in California matters. Where you live, how much money you make, and what kinds of insurance one has matters upon your access to health care and being able to receive the types of services that we will talk about today. That should not be happening, and that's why we're speaking up. We need to recognize that other attacks are occurring, whether it's work requirements for Medicaid or immigration policy, the separation of children at the border from their families, the 2020 citizenship questions, which would really change the types of services that are available to individuals. This is clearly an erosion of human rights. And we need to understand that we live in a state that recognizes that this context and helps to see that the bigoted attacks that occur against women is linked to a number of our efforts to really recognize the importance of diversity, recognize the importance of inclusiveness and social justice. We recognize finally that California is a leader, and we've been a leader in the litigation effort. We have an incredible leader in our Attorney General who has sued the federal government over 50 times. And we hope that this afternoon will identify ways that we at UCSF and our partners, many of you who are in this room, will really be leaders in education, service delivery, research, and advocacy in the face of a looming national crisis related to reproductive health care access. So on that note, I want to welcome our first panel, which will be moderated by Dan Grossman.
Great. Good afternoon. My name is Dan Grossman. My pronouns are he, him, his. I'm the director of ANSIRH. I want to welcome our first panel up here. I also just want to say that we're going to be doing questions at the end of both of the panels. I think that is mostly what I wanted to say. I just wanted to welcome this incredible panel of national experts. We have Renee, Bracey, Sherman from the National Network of Abortion Funds, also known as the Beyonce of abortion storytelling. Erin Grant from the Abortion Care Network, which represents independent abortion providers, which, as many of you know, provide the majority of abortions in this country. And Stephanie Toti from the Lawyering Project, who also just happened to have argued Holman's Health versus Hellerstedt before the U.S. Supreme Court. And we're so honored to have all of you here to talk about what's happening, give us a national perspective about the opportunities and threats. And so each of our panelists is going to have a few minutes to give a few remarks. I think, Renee, we'll start with you.
Great. So thank you, Dr. Grossman, for that wonderful introduction, and to ANSIRH and UCSF for having me. As Dr. Grossman said, my name is Renee Bracey Sherman, and I am the Senior Public Affairs Manager at the National Network of Abortion Funds. For the past 25 years, with our network of 70 abortion funds representing 41 states, the National Network of Abortion Funds has built power with our members to remove the financial and logistical barriers to abortion access by centering people who have abortions and organizing at the intersections of racial, economic, and reproductive justice. We envision a world where every reproductive decision, including abortion, takes place in thriving communities that are safe, peaceful, and affordable. We envision a world where all people have the power and resources to care for and affirm their bodies, their identities, and health for themselves and their families in all areas of their lives. As we shift the conversation about abortion, we believe that it will actually become a real option without shame or judgment. At the National Network of Abortion Funds, I run We Testify, which is a leadership program dedicated to increasing the spectrum of abortion storytellers in the public sphere and shifting the way the media understands the context and complexity of accessing abortion care. We Testify seeks to build the power and leadership of abortion storytellers, particularly those of color, those of rural and conservative communities, those who are queer identified, those with varying abilities and citizenship statuses, and those who needed support when navigating barriers to accessing abortion care. I just want to shout out Laji Dwaz, one of our We Testify storytellers, local here in the Bay Area. I have to tell you, it feels really refreshing to be back in the Bay Area where I found reproductive justice and found my home in abortion funds. How many of you know about Access Women's Health Justice? Yes, thank you. And the folks that are from Access, they're here, right? Yes, you are. I just want to thank you for your work. So many years ago when I started sharing my abortion story, the folks at Access taught me about reproductive justice. It's a framework not only looking at the right to an abortion, but ensuring that everyone has the rights and resources to decide if, when, and how to create and grow their families, and the ability to raise their families in safe communities free from state-sanctioned violence and harassment. I don't know if Gabby's here. Gabby from Access. She's on her way. So when she gets here, you guys have to give her a shout out because she did the first training where I became a practical support volunteer. And as a practical support volunteer, that meant that I opened my home to complete strangers, traveling from Fresno, Humboldt County, and all over the state to San Francisco and Oakland for later abortions. I met up with abortion patients to give them gas money. I welcomed them into my home. I took them out to dinner. I drove them to their appointments. And it really changed my life. Through Access, I learned firsthand about the barriers that others were facing in a supposedly progressive area with supposedly a ton of access. It showed me that there's no such thing as a right without access. And even with few regulations and laws, access can be next to impossible. And that's actually why abortion funds exist. Roe v. Wade legalized abortion in 1973, but shortly thereafter, Henry Hyde, a conservative representative from Illinois, my home state, I'm really sorry, my bad, he added an amendment to the annual budget which bars Medicaid recipients in particular from being able to use their insurance to cover abortions. His goal was specifically to bar people from using their insurance, but he could only impact poor families. So he did. But abortion funds stepped up to fill that gap where the government is refusing to care for its people. Abortion funds have always been working to support folks as they navigate financial and logistical restrictions to abortion. Abortion funds are local organizations that help people with getting everything from their door to the clinic and back home again. Abortion funds help pay for abortions for those who can't use their insurance. There are helplines that folks can call in their local cities and states and say, hey, I need help. But unfortunately, there's a huge gap between how many people call and how many people abortion funds are able to support. Just to give you some numbers, in 2017, there were over 150,000 calls to abortion funds, but abortion funds were only able to help 29,000. It's a huge gap. But with that support, they're like the little engine that could. And they do everything from they fund abortions, they coordinate rides and flights to clinics, they act as translators, they help people find childcare, book hotels, open their homes, and serve as doulas, holding hands so that abortion fund callers know that they're not alone and they're loved. Abortion funds are there when everything feels scary and callers feel like they have no one else to turn to. It's a network of additional support when it feels like the world is against you. As many of you know, this moment we're faced with, where Roe is hanging on by a thread, I guess, if even that, it didn't come by accident. It's been part of a sustained dismantling of access for decades. It's been a racist, classist, and targeted attack against communities of color, queer and trans people, immigrants, disabled people, and young people. And it was designed this way. And honestly, it's nothing new. And while I know many of us feel really nervous during this moment, I know I do, the thing is that abortion funds are ready. We were built for this moment. And that doesn't mean that we aren't scared shitless. We are definitely losing sleep. I know I am. But it means that we are doubling down on our values and what we've been doing for decades in preparation for this moment. Last week was the 10th anniversary of Dr. Tiller's assassination, and we hold his memory alive with his mantra of trust women. And through this moment, we're holding our values close and trusting each other. I know a lot of people say, well, if Roe falls, wealthy people will always be able to pay for their abortions and people with lower incomes won't have true access. And that's true. But I actually think that we need to have a more nuanced conversation than that. The reality is most Americans don't have $1,000 saved, and an even bigger percentage don't even have $100 saved. So this leaves many people without the support they deserve. It leaves people without the ability to get the care that they need. And as our executive director, Yamani Hernandez, says, paying for people's abortions is a revolutionary act. It's the redistribution of wealth, and it's making a legal right actually possible. But the reality is that even with fully funded abortions and no restrictions, the work of abortion funds will continue. People will always need a ride to the clinic. They will always need a loving hand to hold. And abortion funds, we will always be there. What we really need is for more people to join us in this radical resistance. We don't have to make this a fight. We can change the conversation about abortion by centering people who have and need abortions and showing up with love. We can change the conversation by talking about our values and what it means to not only support abortion access, but to show up for a complete stranger in a time of need and be that source of unconditional support. So what I'm asking of you at this challenging moment and in the future is for you to join us. As we say at the National Network of Abortion Funds, everyone loves someone who's had an abortion. And we're asking you to take that radical leap and show up for abortion access and for those that you love. So tonight, I hope that you'll join us in creating this future. And no matter what happens to Roe, abortion funds will be there. Thank you.
So Erin, I was hoping you could tell us a little bit from the provider perspective and tell us a little bit, what is the Abortion Care Network and how do you all do your work?
Okay, hi everyone. My name is Erin Grant and I use they and them pronouns, and I'm the Deputy Director of the Abortion Care Network. And whenever I'm asked to speak and someone will ask me, like, what does Abortion Care Network mean and what do they do, I actually just give that right back to you. So I have a feeling that everyone in this room knows what abortion is, but can somebody define care for me? I'm going to wait. With a room full of providers and people that want to be involved in this movement, I really believe that you can define, one person can just shout out a definition of care.
Emotional support.
Okay, emotional support. And can somebody else define a network? Sure. So we're abortion emotional support group. In some ways, resourcing out of a crowd what you consider us to be is really important. We are some of that. We're an emotional support group for providers, and for the providers that actually hold on to the majority of care in this country, and for providers that are providing the majority of second trimester care. So I want to really piggyback off of what Renee is talking about, because I think that our organizations are in direct alignment, because we have a situation, right? We have a situation where we're moving human beings around and then we're putting them on someone's doorstep. And that doorstep most likely is a clinic that I represent. So it's important to talk about who we are and who we're not. We are not federal health centers. We are not federated together. These are individual clinics, or they're clinics that have a single owner that have multiple sites. So there's a lot of nuance in that, and I want to just open that up because I think that reproductive justice does push us to have a nuanced conversation about birthing, abortion, adoption, foster care, and carceral punishment. So if we're able to just like hold that for a moment, I'm going to go back to who ACN is. So I have the pleasure of being a voice of many of the people that actually are responsible for providing this care, and that say that they want to do it connected to each other and do it well. And that doesn't mean that we all do the same thing. But we do a couple of things that make us very unique. Majority of our clinics are not medication only. We only have about 5 of those in our network. So if you land at one of our clinics, we're going to be able to help you in a way that is tried and true, and regardless of maybe what you thought you were going to get that day. So if you find out information like you're above 10 weeks, you're not going to leave. We're going to see you. Another piece that is really, really important about ACN is that there is a standard around understanding and being willing to be moved in this political moment to a higher calling of values. And we just started this, and as a part of clinics, that's really important. That's where we get to closer alignment, right? UCSF, or Women's Options, is located here in San Francisco, and that is one member. There's so many clinics in California. But something that touches my heart is when I think of, we have a clinic in Chico. And during the fires, that site was offering abortion care, but they were also one of the sites for water distribution, for burn relief, for housing, right? So we have these clinics that are saying, we want to do abortion, we want to care, and we want to be a group. Okay, so that's a really easy way to talk about us. The next thing that I think that is just super important to say again is that these are individual businesses, and the majority of them are for profit. And that's something I'm really proud of. I came from for-profit work, and it's not anything about nonprofit work, but it is about the structure. There's an institutionalization of being for-profit that leverages differently. So a majority of our clinics are not Title X clinics. The majority of our clinics are not 340B clinics. When you're talking about who is going to be harmed by these things, we might never actually be touched by some of those areas. But do you know what really is going to derail us? 1557, right? When you start to tamper with transgender care. Because we're also offering that as well. When you have sites that are holding on to so much care, that means that we might be the single site of reproductive health within your community. And so when we're looking at something that I don't feel great about being here today, when we look at the state of Alabama, we see how being nonprofit meant that there was a lot of dollars raised. But Yashika Robinson, who is a Black OBGYN who is providing abortion and catching babies, received none of that. Okay? So when we're talking about who is the most marginalized, who's the most affected, when we talk about rooting ourselves in values, we also have to recognize where our clinics come from, who our clinics serve, and the historical disparity between Black-owned, Indigenous-owned, trans or queer-run healthcare facilities. Who is actually delivering that care and who is trusted to deliver that care to their communities consistently? So I want to go back just again to say that there's a lot of fights to fight, right? And it's very easy to get distracted in our fights about how do we advance abortion care in this country. The way that we do it is through being innovative, and it's also through really focusing on the person that's in front of us, focusing on our values, our desire to show up and to provide and continue to provide that care. So that is a unique difference. We are abortion first. We are not 2% of our business. We are abortion first. Another thing that I want to say is that in these moments, in this political moment, it's very easy to latch on to a large threat, Roe. I'm very proud of our members because we did just have a meeting where we could source some information from them. And Roe was never going to protect them. And Roe was never the issue. And if you ask any provider, they will be very honest with you. Roe is not the key. The key is the distrust and the mistrust of bodily autonomy. And so for us, what we know is that when we look at the fiscal, the business side, that the strangling of clinics, the closures, the 50 closures of clinics, happened over a course of, you can correct me, Renee, but I think we're at 453 bills that have been introduced in the last 5 years. So it's great for us that you want to show up in this moment, but we really needed you 5 years ago when we were being taken advantage of, when hundreds of thousands of dollars, $250,000 every year was being shelled out to bureaucracy. That's broken in our country. That's not unique to healthcare. We want to be honest that we want to stay. We want to provide excellent care. The question is whether you will be honest with your family about wanting us to be here too. We are dependent on people who have abortions to tell their own stories, because we have our own story to tell as well. We have stories of medical assistants that are racially harassed. We have stories of patients that are in their 3rd trimester that have been to 7 states. We have stories of physicians that have 2 practices across the street from each other that see the same person and have to create individual MRNs to be able to separate them out because of the type of care that they're receiving, but not because of them. And then the last thing, because Dan, I think you're going to move me forward, is the strategies. I don't want to derail anyone, but the strategies that we are using currently is to make sure that you're aware of us and to be included in the conversation. We have a large entity that we work closely with, a few of them, and they've been very honest with you, the public. They only do 2% of this care. And I want to challenge you to be critical thinkers and ask where that other 98 is coming from.
Good. Thank you so much. So Stephanie, in 5 minutes, can you give us a whole overview of the legal landscape we're facing here?
Sure, no problem. Can folks hear me? Okay, great. So I'm going to shift gears and talk a little bit about the courts. And the courts aren't nearly as inspiring as the clinics or the abortion funds, but they are an important piece of the puzzle. So here's an overview. I suspect that many people in this room are deeply concerned about the changes in the judicial landscape that have emboldened states across the country to enact these draconian bans on abortion. Will these bans be upheld? Will the Supreme Court overturn Roe v. Wade, which has guaranteed the right to safe and legal abortion for nearly 50 years? As we consider these questions, the history of the Supreme Court's abortion jurisprudence serves as a useful guidepost, and I'd like to briefly recall that history and then take stock of where we are now. Since the Supreme Court decided Roe in 1973, its abortion jurisprudence has hardly been a steady march forward. All along, it's been more like 2 steps forward and 1 step back. Roe recognized for the first time that the Constitution guarantees every woman, and by implication every pregnant person, the fundamental right to end an unwanted pregnancy. This was clearly a major advancement in the law. But just 7 years later, in a case called Harris v. McCrae, the court held that the government could prohibit public insurance policies like Medicaid from covering abortion. That was a case upholding the Hyde Amendment that Renee talked about. And in doing so, the court excluded low-income women from Roe's promise of equality and self-determination. Over the next decade, the Supreme Court struck down a number of restrictive abortion laws. But the court's membership became steadily more conservative during that time as Ronald Reagan and George H.W. Bush filled 5 vacancies on the court during their collective 12 years in office. Several of their appointees expressed skepticism about the validity of Roe, and following the appointment of Clarence Thomas in 1991, it was widely believed that the Supreme Court was poised to overturn Roe entirely. The next abortion case to reach the court was Planned Parenthood versus Casey out of Pennsylvania in 1992. Much to everyone's surprise, the Supreme Court did not overturn Roe then. To the contrary, a majority of the court reaffirmed its central tenet that the Constitution protects the right to end an unwanted pregnancy as a fundamental right. but the court relaxed the standard by which abortion laws are judged, giving states and the federal government more leeway to enact restrictions. The court's abortion jurisprudence reached a low point in Gonzalez v. Carhart, a 2007 case that upheld a federal ban on a method of second trimester abortion, giving weight to unfounded claims that women who regret their abortions given unfounded claims that women often regret their abortions and suffer psychological harm as a result, the court held that Congress was justified in banning the procedure despite evidence that it lowered the risk of complications for some patients. Gonzalez was undoubtedly a step backward, and the decision emboldened hostile states to enact increasingly onerous restrictions, which have proliferated. Roughly a decade later, the court's zigzagging abortion jurisprudence took yet another turn. In Whole Woman's Health v. Hellerstedt, the Supreme Court struck down a pair of Texas laws that had threatened to shutter abortion clinics all across the state. In the process, the court held that a law is unconstitutional if it imposes burdens on abortion access that are not justified by proportional medical benefits. The court further held that the burdens and benefits of an abortion law must be established by credible evidence, not speculation or junk science. Whole Woman's Health was a major advancement in the court's abortion jurisprudence, and it promised to put an end to the dizzying array of medically unnecessary requirements for obtaining abortion care that have spread throughout many parts of the country. But that was before Donald Trump was elected president and promised to pack the Supreme Court with anti-abortion justices. He's now had the opportunity to appoint 2 justices to the court, and many people once again believe that a majority of the court is poised to overturn Roe. Whether that prediction will prove more accurate today than in 1991 is really anybody's guess. The court's current term, which will be over in a few weeks, hasn't featured any major abortion cases. The court could hear an abortion case next term, which begins in October 2019 and ends in June 2020. If that happens, a decision would most likely come in late spring or early summer of 2020. I think it's unlikely that the Supreme Court would overturn Roe just months before the next presidential election, but I wouldn't rule it out completely. A more likely scenario, in my opinion, is that the court follows the example set in Casey, reaffirming the central holding of Roe, but further diluting its practical protections. In some ways, that kind of decision would be more harmful than a decision overturning Roe outright, because it would enable states to further diminish abortion access without triggering a big public backlash. Such diminished access would have a disproportionate impact on the most vulnerable communities in our society, and that's where we need to keep our attention and resources focused. Thank you.
So we're going to spend a few minutes. I'm going to ask a few questions, but if you all have questions, building on what sort of the depressing scenario that we just heard, if we get to a point where abortion is no longer available in some states, patients will need help traveling to other states where they can get the care that they need. So what sort of logistic support will be needed for patients? What will be the role of clinics in those states where they can't actually offer abortion care? Can they still play a role doing pre or post-abortion care? And then also, what are some of the potential legal obstacles to this model of cross-state abortion provision?
I feel like I can go first. So the first thing I would say is, if I know we just logged into something, but I would definitely encourage everyone to learn where their closest abortion clinic is. I think that's so easy. But a lot of people, actually, if your friend was to call you right now, you would not be able to find it. And so I can tell you that you can text 202, I'm going to say this very slow, 202-883-4620. You can text hello, and it will point you to the closest ACN member clinic. It will send you to the National Network of Abortion Funds for funding, and it will also link you to Planned Parenthood and to NAF to find clinics that are even closer. So again, we're trying to take some guesswork out of here. What we don't want, what I know our clinics don't want, is for you to invent something to address this issue. We've been working on it for 10 years at ACN. The funds have been working on it for 40, and I don't even know the legal side. So that would be the first thing. The second thing is that a lot of our clinics right now that are on border states are working to hit the maximum gestation. So in Pennsylvania, we're pushing our clinics to hit the maximum gestation because a lot of people are paying attention to Alabama. This started in Ohio. This was workshopped in Ohio and Iowa first. And so we're forgetting about the Midwest. We're forgetting about those states. So that's a lot of what we're doing right now, is just trying to make sure that people actually know where they can go to receive the care that they need.
Yeah, I think, like I said, abortion funds, I mean, we're not new to this, we're true to this. We've been doing this for a long time. Honestly, this is how I got my start, doing practical support. I was saying, Gabby, I know you just got here, but what I was saying is that you had trained me in abortion funds or in doing practical support, and I think that honestly, that is the most radical thing that you can do at this moment, is open up your home, open up your car to someone who needs to travel for an abortion. I literally last week had someone who's had a 3rd trimester procedure, and I was taking her to the clinic, and there's just such beautiful intimacy that happens when you're taking someone who's often traveling alone and has to sit in a hotel and doesn't really have anyone to talk to. And I took her out to dinner, and we just talked about what was happening right now. We shared our abortion stories. Just that radical piece of just being there for someone. It's just so beautiful, and I think that it's a great way that we can actually combat the larger conversation of the rhetoric around abortion that is just so disgusting and so vile, that we can show someone humanity. So there's a lot of networks out there, a lot of abortion funds out there that you can get involved with and really make an abortion a reality for someone right now. So I would hope that you all do that. And I think we're going to see that we're going to need more people who are donating to help folks fly across the country to get abortions, drive to other states, and need homestays. So it's really up to all of us. And just because you live in California, I lived here too, I thought there wasn't a need. There is a need. There's always a need. And so we can all get involved and we can all do our part.
And there may be even more of a need, right? As more patients travel here. Stephanie.
Yeah, absolutely. So in terms of folks having to travel across state lines to access abortion care, there's no legal barrier to an adult pregnant person going to another state. The Constitution protects the right to interstate travel, but
for now.
Right, for now, right. It's also protected by the Commerce Clause, and that's one that the Supreme Court cares a little more about, maybe. But there are potentially obstacles to young people traveling across state lines to access abortion care, particularly if they don't have the support of their parents. So I think that's a population that we need to be, really concerned about what's going to happen to their access. Also, there could potentially be implications for medication abortion, which typically involves a 2-medication regimen where the first medication is taken immediately, but the second medication is taken 24 to 48 hours later. It's not clear that a pregnant person will be able to travel back to their home state with that second medication and take it there if the state law bans abortion. So it may be that more folks are needing to have overnight travel to remain in the state where they access the medications in order to complete the procedure lawfully. I think that's also something we need to be aware of and to prepare for in terms of distributing our resources.
Oh, I just realized something. I'm in California. Sorry, I got here at 2 a.m. Y'all have to pay attention as what people are saying about your state. You have to pay attention to Catholic mergers. I know that that's a controversial thing for me to say on this stage, but I want to say that just one more time, that if you're in your EDs, in your emergency departments, if you're having struggles around miscarriage management, that is just a tick away from where we are going to be. So I forgot to say that.
Thank you. So I wanted to spend a few minutes talking about self-managed abortion, so meaning people using things on their own to end an unwanted pregnancy. We certainly anticipate that self-managed abortion will become more common as folks face more barriers accessing clinic-based care. But I wanted to know if you have thoughts about how will we ensure that people have accurate information about regimens and how to do things on their own, how to get access to medications. I'm curious if you have thoughts about what role clinics might play in providing the care around a self-managed abortion. And then, of course, there are also legal risks that both patients and providers may face. And I'd love to hear some of your thoughts on that.
Yeah, so I want to say that I actually trust anyone to make any decision with their own body. And I know many of our providers operate from that values-based place. As a part of an institution, it depends on how the institution crumbles. That will get us all free. And then we can kind of build back together. But as long as I'm a part of ACN and representing institutional care, the places that we're starting to have conversations is whether our sites will be able to maintain ultrasound and radiological and laboratory practice if abortion is banned in their state, so that we can help with what we would diagnose as miscarriage management or pregnancy loss and support. Right now, that's not within a lot of care in states that have really tight, like I said, bureaucratic hold on abortion. You're not necessarily allowed to do miscarriage management or diagnose through ultrasound in my home state of Pennsylvania. So a lot of what we're ramping up for is to support ourselves as we encourage risk. We want to acknowledge, I think, as providers that we're willing to take the risks that our patients are. But we also have licenses and buildings that historically, if an abortion clinic closes, it does not reopen. So our strategy has to be able to merge with funds, provide them with brick and mortar places as well. So I think we're looking at several approaches to keep the facilities, because I do believe that we will win.
We will win.
Yeah.
Abortion funds are ready. We have on the National Network of Abortion Funds website how to end a pregnancy safely using pills. And we support people choosing to end a pregnancy in whatever way is best for them. We know that there are folks who use teas, who use herbs. I work with some storytellers who have ended their pregnancies both successfully and unsuccessfully with herbs and teas. It is a reality. I think I get frustrated because people talk about self-managed abortion as this pre-Roe thing that we can't go back to. No, it's happening now. And it also, just because something is illegal does not make it unsafe. Legality is just an idea, right? Marijuana, hi, illegal, well, not here, but everywhere else, illegal, but it's safe, right? So we know that a lot of the methods for self-managing an abortion, they may be illegal, but they are safe. But what's on us is to make sure that folks have access to the safe methods for what they need, right? And also making sure that folks have legal protection, because we know that folks who have been self-managing their abortions or suspected of self-managing their abortions are being criminalized, particularly communities of color. So we want to make sure that abortion funds are at the front line, giving the information to folks who might be self-managing their abortions so that they know where the risk is. It's not necessarily in safety right now, it is in legality. It is the legal risks. And I'd encourage you all, there's a lot of folks who are kind of talking about, we won't go back, women are gonna die. Yes, okay, that messaging is very, dramatic, but the reality is that's not necessarily what's going to happen. We know that it's actually the criminalization piece. So we need to really talk about the intersection of our criminal justice system or injustice system and healthcare and communities of color. That is the conversation that we need to have, and making sure that folks are able to get the care they need as safely and legally as possible.
Yeah, absolutely. Criminalization is a huge risk of self-managed care, both for the pregnant people themselves who are having an abortion, but also for the folks who might help them in that process, who the law might consider co-conspirators or aiders and abettors. I think access to information is also a really critical piece to this, because as Renee said, there are safer ways to self-induce an abortion today, and safe ways to self-induce an abortion using the medications that a clinician would use, that a healthcare provider would use. There are lots of studies that demonstrate that folks can use these medications on their own safely, provided they have the right information about how to do so, and they have access to legitimate medications and not black market substitutes or other things. And so I think it's important that for the legal community to try to delineate the boundaries between what healthcare providers and what supporters can do within the bounds of the law, even in a state where there's an abortion ban, and what is outside the bounds of the law. So healthcare providers can certainly provide pre-abortion care to a patient, including gestational dating, including providing accurate information about what medications will induce an abortion safely, how to use them, what to expect afterwards. And healthcare providers can provide post-abortion care and treat any patient who might be experiencing a complication, or who just might not know if what they're experiencing is normal or is a complication. Healthcare providers can do that without any risk. The risk comes from encouraging someone or providing material assistance in having the abortion, in sourcing the medications, in possibly bringing the medications across state lines. And I think, that's where I think we need to focus our legal advocacy to try to eliminate those criminal barriers and to encourage prosecutors not to use their resources, not to use their discretion to go after folks who are seeking to exercise their basic rights to control their bodies and to take charge of their care.
Thanks. Should we open it to questions?
Sure. We have one that, or actually I have two that are pretty similar, so I'm just going to ask them both together. Amid legal panic, there's been a lot of fundraising that's been rooted towards Planned Parenthood. How can we better channel those energies and funds to indies and abortion funds? Sub-question, local fund or national network?
I mean, I work at the National Network of Abortion Funds, but give to your local fund.
Yeah, I would say that abortion providers, independent abortion providers, specifically ACM members, we are, like I said, it's funny for me to be on a panel at the same time as Renee. Most of the time I don't feel like we both need to do it at the same time. But I will say that we are in deep communication with the funds that surround our clinics. Those are relationships that were predated us all wanting to jump on to figure this problem out together. Those relationships have to do with the fact that we have very low turnaway in this current climate because of the funds. So we're already in that discussion, and yes, I don't think that national to local, for me as somebody who represents the clinics, is necessarily important. From us, I want to say, if you really want to give to a clinic that's a for-profit clinic, be radical, get to the root of the issue, and redistribute your wealth. We can accept your money, you just don't get a tax break for it. We have PayPals. It's not like we're like, if you cut us a check, nobody's going to turn it away. But I also don't want to continue the nonprofit industrial complex idea that by giving money to healthcare, that you're a part of a stopgap. We're going to spend it immediately. We're going to buy more supplies. We're going to fix parts of our building. But that's not, in healthcare, money does not work that way. The end is never ending, right? The need is never ending. So if you want to give to a clinic, let me know. I will hand deliver that $1 million. Choices needs a birthing center. We got stuff to build. We're not downtrodden about continuing care.
one quick thing I'll add is that I think there's always this tension of national versus local, and we actually need support at both, right? Because so at the National Network of Abortion Funds, what we do is make sure that abortion funds have the support so that they can actually grow. Most of the abortion funds don't have staff. They're volunteer run, and so we want to help them build the infrastructure so that they can have staff, because we actually have data that if an abortion fund has staff, they're actually able to help twice as many abortion fund callers. But I also think that it's really important that you give to your local community, get involved with your local abortion fund. I just told you, the folks from Access are here. Talk to them, figure out how to get involved. Because I think, I don't know, I just think that you're working with your local abortion fund is a way to just find community and to make sure that you buy local abortions.
So we just have a couple minutes left, and I want to just ask you, we've been hearing a lot about kind of depressing threats, and I want to hear, what are you most excited about related to abortion access or care?
Yeah, I think Stephanie should go first.
Sure. There have actually been a lot of really exciting developments at the state level where some states have stepped forward to say, we want to protect abortion access, and we want to make sure that no matter what the courts might do, people will continue to have access to safe abortion care in this state. So Nevada recently passed a law decriminalizing abortion and removing some of the requirements that had previously existed in that state for biased counseling prior to obtaining an abortion. Illinois is just about to pass a similar law that codifies the right to abortion and eliminates many of the restrictions in that state. Maine has two laws expanding access. One mandating coverage, health insurance, public health insurance coverage for abortion care, and one eliminating restrictions that have previously prevented qualified advanced practice clinicians, like nurse practitioners and nurse midwives and physician assistants, from providing care. Vermont is moving forward with a bill to codify a right to abortion access in that state, and hopefully these states will serve as models for others to expand access and to codify the right to abortion in their state constitutions or in state law. And there's also some proactive litigation going on around the country, including in state courts, which aren't bound by the rulings of the U.S. Supreme Court and which can give voice and effect to their state's own constitutions. My organization just filed a lawsuit in Minnesota seeking to expand access. Yep. There are other lawsuits going on around the country. I think all of that is a positive development.
I'm just going to say what excites me every single day is the number of people who've had abortions who are speaking up and saying that they had an abortion. Shout out to every single one of you who is sharing your story and changing the conversation. I am proud to work with 45 abortion storytellers through We Testify, including trans and queer storytellers who have been speaking out, changing the game in the last couple of weeks. I sat with a young 18-year-old HK who testified before Congress about being a teen mom and needing an abortion. Just the fact that folks are unafraid and are being counted, Laji talks openly about being undocumented and getting a deportation order and needing an abortion and the complication that is, and that our nation does not provide for people to be able to parent if they want to, that our nation's laws around immigration and who gets to parent are disgusting. And I think that, you and all the We Testify storytellers just make me so proud every single day. And I am just so thankful to work alongside you and everyone else who shares their abortion story and is counted.
Great. I only have 1 minute. I started to tear up, so I needed to take a deep breath. I have to say that what gives me hope and what gives me light is to really see providers starting to understand racial and gender inequity. In my lifetime, if I can get anything to happen within the abortion rights movement, is for us to grapple with white supremacy within this practice, and also the historical aspect of domination and violence that has happened to communities, brown and black communities and indigenous communities. So for me, seeing people actually, instead of providers specifically, instead of being pulled in 8,000 directions by the political landscape, and actually buckling down and having conversations within their staff and within their patient population about reproductive coercion, and thinking that abortion clinics may be a part of a reproductive justice like I'm getting freaked out right now, but thinking that abortion clinics could be a place that reproductive justice as a clinical practice could start, watching clinics flip into hands that have never provided that care. Giving Kwajalein Jackson a clinic was a goal of mine. Seeing Yashika Robinson, seeing black folks own clinics in the South is a goal of mine. Thinking about Laji running a clinic is a goal of mine, because those intersections matter, and we're separating everything out, and we're not winning for the most marginalized. So as a queer person, for me to think that I would actually encounter a provider that would give me the option to have a family, right? To not discount my ability to raise a family. And if I can do that for somebody 20 years down the line, then I will be so set.
Thank you. Well, join me in thanking this incredible panel. Thank you. I'm going to hand over the mic to Monika McLemore, and we're going to do a little transition of the mic switch here.
How you guys doing tonight? Good. So while they're being demiked, for people who don't know me, my name is Monika, she, her, hers. While they're being demiked, I would like the audience to join me in a round of applause in celebrating Erin Grant, who is being honored tonight by the New Voices for Reproductive Justice, and she's here with us. They're being honored tonight and being recognized for being a powerful leader within the Black LGBTQIA community who advocates for reproductive justice, and they are receiving the Voices of Change Award tonight, but they are here with us. So can we give her a round of applause, please? They didn't know I was going to do that. Last weekend, the DCCC was here, and we had a Democratic convention, and our governor, Gavin Newsom, got up and said something really inspiring. And for those of you who didn't hear it, I'd actually like to give you a little taste of what he said. The headlines were almost correct in the news, where he invited people to come to California to have their abortions, which I thought was really interesting and fascinating. And as a clinical nurse, I got a little nervous because I was like, oh, we need some staff. But, I'm sweating, right? But one of the interesting things that he wrote, along with the governors from Oregon and from Washington State, they codified it in a letter talking about their commitment to reproductive health and reproductive health services provision. So I think I just want to read you what they wrote, because for me, it was very, very inspirational, and I think it really sets the tone before I introduce my colleagues and collaborators, who's the next panel. In the absence of federal leadership on these issues, states must step up and put in place their own protections, both in statute and in their state constitutions, and through the expansion of essential family planning services and education to defend every American's right to reproductive freedom. I actually was really, really moved when I read that, and I was really, really grateful that there was some press around it, because he really set the standard for how we should be thinking about our essential work and really being able to provide the care that people need. So that said, I'm going to ask some very special people who I've known for a very long time to come up and join me on the stage. And I will first introduce Dr. Eleanor Drey, and she is the medical director of Zuckerberg San Francisco General Hospital. For the people who don't know, I have clinically been fortunate enough to work with Eleanor for the last 18 years, and I'm very grateful that she can be here tonight to share with us. I'd also like to call up Dr. Jody Steinauer. I see you coming. I see. She's got her mic on now. She is the director of the Bixby Center for Global Reproductive Health and also works at the Women's Option Center. And I've been very fortunate to work very closely with her and the team from Innovating Education and Reproductive Health. And so very glad that you have your microphone on. And then you have yours on. Okay. And let me call the stage Ushma Upadhyay. And I have to tell you, Ushma was one of the first people at ANSIRH that I had opportunity. She and Lori Friedman really embraced me in a way that I will forever appreciate because she was doing some work with my mentor, Dr. Diana Taylor, on the Health Workforce Pilot Project number 171 to be able to provide the evidence that was necessary for advanced practice clinicians to be able to do aspiration abortions. So that said, the panelists will start and we'll provide you with some brief comments, and then I'm going to ask them some questions. Eleanor.
So I was asked to speak about what the role of academic institutions in Haven States would be. So a place like UCSF in maintaining and expanding abortion access. So what I would say is that we're lucky in academic institutions. We're sort of known for quality and high-risk abortion care. So as such, we are in the privileged position of providing abortions beyond the first trimester for women who are most at greatest medical risk, who may have the most medical comorbidities, the most medical problems. And also just going later than other places may be able to offer. So what I would say is really quite unusual in our city is that at San Francisco General, where we have a Women's Option Center that you heard about, we're part of UCSF, but we're also part of the Department of Public Health. And what's I find incredibly moving is that the mission of our hospital as part of our public health department is to be a safety net for uninsured and underinsured residents of San Francisco. And yet the Department of Public Health has understood for decades now that they actually are a safety net for abortion care. And that has given us a lot of support in providing for patients coming from beyond our city's borders, even from beyond our state, who need our services. And beyond that, the Department of Public Health and our city attorney had the understanding that, for example, when there was the federal abortion ban, it was their idea to join that lawsuit on behalf of the patients served within our hospital, saying that we ought to be able to provide these services. And then this week, they've understood that the overly expansive Health and Human Services interpretation of conscientious objection, which I find so incredibly offensive, how they're interpreting it, that our city attorney's office is like, sign us up. We're going to sue the Trump administration on this basis because what they should be talking about is what is the role of conscientious provision. And so it's really amazing to be in a place like this. So yes, we're the safety net as UCSF and San Francisco General for our patients, but beyond 24 weeks, we're allowed to also provide a safety net for those patients. And what that's meant within San Francisco General is that many of those patients cannot get these services at an affordable price, and we are able to be a safety net for those patients. What I don't know, as abortion becomes more restricted, is as I imagine more patients coming to a Haven state, that will require increased support as a safety net, again, beyond the original mission of our hospital to help those patients. As an abortion provider in an academic setting and in San Francisco, I'm from Missouri. So, you can talk about Henry Hyde being from Illinois. We, in my home state, gave everybody Clarence Thomas. So we all have things that we feel not so good about, perhaps. But I feel very lucky to be here. I feel like in an academic setting, it's amazing to be able to provide the evidence to fight the restrictions and to be a proud provider of outstanding abortion services. And as I said, I can't imagine not providing those services. I know on a day-to-day basis how critical those services are for the patients we see. And I cannot imagine being in an academic setting where I would be in a restrictive state. I can't really wrap my mind around it because I think, well, it's easy for me in San Francisco to say, what would I do? But I don't really know what I would do, but I can't imagine being told I would stop doing what I'm doing. I feel very lucky to participate in the care that I'm able to offer here. Every day I care for patients I respect so profoundly. I admire them, whose stories and lives touch me and motivate me, and I can't imagine not caring for them.
Thank you, Eleanor. And I'm going to try. Do you have water? I want to make sure your voice is protected. Let me ask you another question, because I think this is something that I think we all struggle with, and that is we've heard about the onslaught of abortion restrictions and how it's being compared to a crisis by a natural disaster. But how do we model? How do we prepare for what seriously is a man-made political disaster? How are we going to get ready?
Well, so, I've told people that I went to what is really an unimaginable, there are a series of regional meetings about how to gear up for what is literally it is a man-made disaster, and it's a political disaster. So these regional meetings are large groups of haven states and hostile states, providers and advocates, and everyone getting together to say, okay, we have to put together kind of a disaster plan. And that's really what we're talking about doing. So how do you maintain the brick and mortar that, you need the brick and mortar places not to go away, because you hope that in those hostile states that you don't lose those places, because it's very hard to get them back. And those people are needed. And for patients seeking abortion care beyond 10 weeks or beyond 20 weeks, if you move entirely to self-administered abortion, how do you maintain the services for people at more advanced gestations? So I think there are practical issues around sharing resources. There are very complicated issues, as Stephanie was talking about. What do you do about abortions that may start in one state and end in another state? The importance of funds can't be overestimated, and how that will translate is really important. But, I think that going to that regional meeting and thinking about teenagers in particular, what are we expecting teenagers to do to continue to get safe abortion care? It's kind of mind-boggling and really giving me chest pain.
Yeah, thank you for the insight. Do you have thoughts or ideas about how we can support academic institutions that are really, priding themselves on offering outstanding patient-centered evidence-based care, including abortion care like UCSF, but are in some of those hostile states? How can we further advance conscientious provision and support our colleagues that may be in a more hostile state?
I don't really know what to say about the hostile states. I don't know. I mean, I actually would like the people who are here from Access to stand up.
Yeah.
If you wouldn't mind, because I really would like people to seek them out. I again want to say, you know, as we look to this, this really, as I said, kind of unimaginable future, we already are heavily reliant on Access, Women's Health Justice, for their hotline, for their practical support volunteers who have such a rich understanding of our patients and their needs. The more people, as was said, the more people who are trained to give practical support now by Access, as soon as possible by Access, those are the people who will then be able to support whatever people need to come from hostile states. So I think that model of the abortion funds who really provide, they're like concierge, they're like wraparound care. And the example I can think of that I really was, there was a teenager coming really from a far way away to our clinic, and her parents didn't want her to get these services, and Access came up with a plan for her where the same woman came and picked her up for a babysitting job 2 days in a row and brought her all the way to the clinic so she could babysit all day, brought her home at the end of her babysitting job, brought her back the next day. I mean, that kind of just attention to what would allow her to get safe care with a family that was not going to help her is what places like Access do. And you know, on a more basic level, again, when I went to this Western regional meeting saying, oh, patients are going to travel, we have patients who have trouble getting from Oakland to San Francisco. And that is a real barrier for people. So to think that we're going to be able to really help everyone who needs this care get, you know, like for people who don't have like people are like, oh, get on a plane. Well, not if you've got no documents, not if you've got no way to get on the plane. You know, it's one thing to say, oh, you've never been on a plane. Well, how are you going to do that? So those are just intense barriers. So I think when I think about what we'll need in a haven state, I imagine not only will we need more nurses, more counselors, more support, but we probably would need volunteers to be the embedded Access people helping get people here with the level of attention, kindness, and care and respect that patients really would need.
Thank you so much. Thank you. One of the things that I'm doing, I'm flying to Atlanta tomorrow to go accept a leadership award at the Association for Women's Health, Obstetrics, and Neonatal Nurses. And one of the things we're going to talk about is nurse training as RNs and telephone support. Also working with our emergency department colleagues as well as our labor and delivery and OB triage colleagues to really do some awareness raising around the need for abortion care and hopefully really be able to help get us some more staff. I kind of joked about that, but I was very serious.
You know, I just want to say, you know, the patients are so motivating. You know, we have taken care of, because of Dr. Tiller's murder, we've taken care of an increasing number of patients beyond 24 weeks. And initially that was very uncomfortable on our labor and delivery, among our colleagues in labor and delivery, but the patients speak to you. And I think that it has been transformative for when you see the context, when you see what it means, then you just, as I said, you can't imagine not providing the care.
Is there anything you'd like to say that you haven't said yet, or should I move
Maybe
to
I
Jody?
Think you should move on.
I'll move to Jody. Thank you, Eleanor. So Jody, can you walk us through how should we rethink and or restructure training to prepare the clinical workforce to care for patients in a post-Roe United States? What should we be thinking?
Yeah, well, I I wish I got to talk about the patients, but I'm going to try and talk especially about learners, so everyone get excited.
Hey, they get radicalized too.
Yeah, they're really important. So I just wanted to start by acknowledging I see all these people in the room who trained me to provide abortions. So I want to acknowledge you. And just to acknowledge everyone here who trains people and who are learning to provide abortion care. So I just wanted to honor you all. And, you know, Monika, Eleanor, and I are all clinical educators. So our job is to train doctors and nurses to have competence and skills to provide compassionate, patient-centered care. And we are so likely to be able to do that. And of course, part of being able to provide care for patients is to be able to provide abortion care. Abortion is common. Abortion is more common than surgeries to remove the appendix, the gallbladder, more common than hysterectomy. It's about as common as cardiac catheterization, which is a diagnostic test to evaluate whether the heart is getting enough blood flow. It is very common. Obviously, I'm telling you who don't need to hear this, but this is why it is so critical that it is integrated in all schools of nursing and medicine, no matter what type of specialty the learner is in. So that's why I'm talking to you today. And so I want to just start for a second by talking about the current state of training, because we have not achieved an ideal state of training. And then we're already facing extreme restrictions, as we've already talked about. And if we actually entered a time where abortion's banned, training is just going to get more complicated and critical. So, and I just want to honor that I'm really focusing on medicine and nursing, those two professions. I want to just honor that these are just two members of the abortion care team. We have counselors, we have medical assistants, we have volunteers. It takes a lot more to provide care for patients. So what is the current state? Well, OBGYN residency programs are mandated to provide abortion training in all aspects of abortion care, including doing abortions. Family medicine residency programs are mandated to provide training in pre- and post-abortion care and provide the option for family medicine physicians who want to learn to do abortions to be able to learn to do abortions. Abortion is expected to be in curricula of other specialties of medicine, like emergency medicine, so that physicians in the emergency room can care for the rare patient. Remember, abortion is extremely safe, but the rare patient who needs to be seen in the emergency room, for example, after an abortion. All medical students and nursing students are expected to learn about abortion so that they are prepared to counsel patients, to refer patients, and to treat them with compassion. And depending on the specialty, maybe to have more advanced training. So in reality, we haven't really met these goals even today. So we still have 1/3 of OBGYN residency programs without routine integrated training. We still have a majority of family medicine residency programs that do not have integrated training. And we still have many, many medical students and nursing students, including advanced practice clinicians, who do not learn about abortion. So that's where we are in the pre-Roe America, the in-Roe America. So here we are thinking about, we've already had many challenges in restrictive states, but if really we faced a situation where it was banned in many states, we would be in a really challenging situation in education. So I had a few thoughts to discuss. One is we really need to think about expanding the workforce and really think about training in different ways and not necessarily limiting ourselves. I would say, my focus is in abortion training and education, and the people in my community tend to think fairly narrowly. We sometimes really focus on family medicine and OB-GYN and advanced practice clinicians. We really need to think into different disciplines in medicine, or different subspecialties in medicine, and really think about the full spectrum of nursing care, including pre-licensure nursing, and really the whole workforce. That's one thing we really have to do. We have to think differently about curricular content. So we need to think about what would it take to prepare all nurses and physicians to provide care for patients in both legal abortion settings and illegal abortion settings. And a lot of this was brought up by our previous panel as well, but we need to really make sure everyone is trained all clinicians to create a welcoming and non-judgmental space for patients, to really do a better job of educating patients about bodies and menstrual cycles and what it might mean to be pregnant. And then we talked a lot about harm reduction. What are the options if you do find yourself pregnant? And for patients who might choose to self-manage their abortion, how do we counsel them about what is safe, how to access medication, all the things that the previous panel talked about. So this is kind of a different way of thinking in medicine, to really prioritize this harm reduction model as well. Also, we already do kind of a bad job with abortion patients, just getting them to clinics, so counseling them about options, knowing where our local clinic is, knowing how to refer them, knowing about the abortion funds and all of the volunteers who are ready to help them, support them. So we really need to integrate all of that into training. The last thing I wanted to say is that we also really need to worry. I am very worried about the learners in these states without legal abortion. How are they going to learn the skills they need to provide care for patients? I mean, this is a disaster. Already we are suboptimal in our training. So we need to really put pressure, I think, on all schools of medicine and nursing to really prioritize this and to be ready for this if this were to happen. Already we have places with extreme restrictions where they don't actually get to interact with patients needing abortion or being in abortion care settings. But we need to really put pressure on the schools. We need to put pressure on the national organizations who set these rules. So how are we going to handle it if it is a requirement for OBGYN programs to have training if there are no legal abortions in that state? How can we make those residency programs train to competence, right? Same with medical schools, same with nursing schools, et cetera. So we really need to think about it at the level of the national organizations. Our learners need to demand training and think about creative ways to overcome the shortage of patients they will have. So we've been thinking a lot about distance learning and online training techniques, the use of simulation, all of these kinds of other modes of learning that we could integrate in places without access to patients.
Thank you, Jody. It's very, very helpful. Building on what you've just outlined for us, how can a teaching institution like UCSF help train clinicians to provide abortions in new geographic distribution?
Well, that is a tricky question. So many, especially medical schools, are so often centered in these densely populated areas. And so, thinking about how to inspire graduates to go out and practice, to be in clinics on the borders, to be in places where they haven't been before is a little bit challenging. I mean, I think one thing we could do is really prioritizing teams of faculty and learners to provide care outside of sort of the safe space of the academic institution or community. Engage in the larger abortion provider community, get to know different providers, really build a community beyond the academic medicine walls. Every time I've mentored many people and taught people who, as soon as they go work in these clinics that are sort of outside of our protected San Francisco General Clinic, which is so beautiful, they are just so inspired and motivated to continue doing that work. So I think that's one way, is just simply bringing them there and modeling.
And then, do you have specific recommendations or specific things you want to highlight about us as UCSF and really thinking through how we can be expanding the work that we're doing? Because we've had some success, we've had some, barriers and challenges, but how can we really be thinking differently about high quality reproductive health care to people both in California and in other states?
Well, I think that I'll take a moment to brag about UCSF because I feel like we've done some really good things in this world. I'll just start with Monika, who we created Monika. Yeah, she trained at UCSF. No, Monika, you've done incredible work leading nursing training initiatives and really thinking broadly about nursing training initiatives. We already talked about the program that came out of ANSIRH, the data that supported the change to make it legal for advanced practice clinicians to do abortions in California. And I know of at least one of those who's in the audience who does abortions. She's an APC. Yeah, I see you. So we did a lot of that work. We've also led the Fellowship in Family Planning, the Ryan Training Program. I mean, we have really been focused on how to make sure that every single medical student, nursing student, and family medicine and OB/GYN resident is trained to do abortions. So I think we just keep doing that work. I also, the Innovating Education and Reproductive Health program that was mentioned earlier, we created the first ever online abortion course that has been watched by more than 10,000 people globally. And we really need to push, to further develop content and make sure that everyone, really think of this online curriculum as a great tool to sort of educate people beyond physical boundaries.
May I mention something that did come up in the regional meeting, which is, if Haven states are going to take care of more patients, it is important, if we're going to keep training people, for part of the considerations of those patients traveling is to places where they are going to train providers. So, for example, in our clinic, if we had more patients in our clinic, we would be able to accept trainees from other places. But, the way medicine works is that you need a certain sort of critical number of patients being seen for providers to efficiently learn to be safe, respectful, the people who you would want to participate in your abortion care. So I think that the hard thing is, if you need to be efficient, you need to see people quickly. Trainees are not really that. So that has to, so there is a built-in tension there, because they're slow, and you want them to be slow because they need to learn at a pace which is fair. So that is a balance. But at the same time, when I was a fellow and I was training people in South Africa in different clinics, you need a certain amount of volume, because otherwise it's just not efficient learning. And it is amazing and quite moving to see how quickly people can get skills for what is straightforward care. But if you only do a couple procedures in a day, that is not happening, And
then I just wanted, the one last thing I wanted to add is I was also thinking about how important emergency medicine is, and the nurses, the staff, the physicians in emergency rooms are really critical. And I really think we need to be thinking about how to bring these messages to that community to make sure that patients are not treated as criminals, are treated compassionately, and they really know how, this content, which they currently don't know that well.
Yeah, and I just want to say, like in our little clinic, we've trained internal medicine people. One of them's going down to Texas now.
Surgeons, we've trained surgeons.
Surgeons who have gone elsewhere. So, these are skills that are within, and the motivated people, I think, really will take this to places where it's needed.
Agreed. Thank you. So we've heard about clinical care provision, and we've heard about teaching education, but I think we also need to hear about research. And so, Ushma, let me ask you this question. What do you see as some of the methodological challenges to researching the consequences of abortion restrictions?
Sure. So I am a public health social scientist based at ANSIRH, Advancing New Standards in Reproductive Health. I'm one among about 15 researchers, and many of them are here, so I'll try to represent. A lot of the work we all do is researching the impacts of restrictions on women's lives. And restrictions have different impacts. Sometimes they reduce the ability of providers to keep their doors open, and they lead to closures like admitting privileges laws and transfer agreement laws. And sometimes they increase the burdens on people's ability to get an abortion, like the 2-visit requirements and parental consent laws for people under 18. And then there are also laws that outright aim to shame people choosing an abortion. Missouri has a law that requires individuals to have a pre-abortion pelvic exam when we know it is not a medical necessity for a doctor to examine your vulva and internal reproductive organs before an abortion. So in our work studying the effects of these restrictions, one of the greatest challenges that we've had to face is how do you identify individuals who would have had an abortion if those restrictions were not in place? So I think one of the answers is to look for people anywhere but abortion clinics, recruit out in communities. So that there's been some really innovative work. Jenny O'Donnell, who is now at the Society of Family Planning, recruited interview participants at shopping center parking lots. She is a brave person. And I think Walmart. And my ANSIRH colleague, who's not here, who couldn't be here tonight, Sarah Roberts, recruited patients at prenatal care centers. And that has worked out successfully. In my own work, I have a study, a Google AdWords study. We recruited people searching for an abortion provider and who were considering an abortion at the time. We followed them up 4 weeks later and asked them about the barriers that they faced in trying to obtain one. We're working on the analysis now, but at 4 weeks, 50% had obtained their abortion, 20% had decided that they wanted to carry to term, but another third of the participants were still trying to obtain an abortion 4 weeks later. Like, that is a big problem. So what we need is really innovative study designs. We need more acceptance of thinking differently about how to reach people who are seeking an abortion to really understand their experiences.
Thank you for that. I'm really lucky that I'll be presenting some of the innovative study design facility work with Sarah Roberts at AWON. We've come up with abortion facility standards from her important study, and so we'll be presenting those data while we're in Atlanta as well, so it's super exciting. Let's pivot a little bit that as abortion access declines throughout the United States, what are some proactive things you're thinking about? And how can we at UCSF maybe be more proactive in our research question?
One thing I have to say is I have never been more appreciative of the academic environment that we have at UCSF. There's never been a time where I've felt that I have this academic freedom and support. The email we received today, or was it yesterday, where the UCSF disagrees with HHS's decision to stop fetal, stop studying, tissue research. And Dr. Murtha has supported me in difficult research plans, and so I feel very supportive. This week we're doing at ANSIRH an abortion incubator, abortion researcher incubator, and they're all right here. And just hearing about the struggles that they face at their institutions, it really makes me appreciate being at UCSF. But our team, we currently have several innovative trials that we are working on. Our own Dan Grossman has a portfolio of really cutting-edge research projects investigating alternative models of provision of medication abortion, and his powerhouse team is over here. And they're evaluating access to medication abortion from pharmacies, both brick and mortar and online pharmacies. So eventually, the hope is that primary care provider in a small town would be able to just write a prescription and for their patients down the road. And I'm in the process of designing a study to test the feasibility, safety, and effectiveness of a telemedicine model of abortion. I'm working with Dr. Karen Mextroth in our department. And that's the California Home Abortion by Telehealth study. And this study would be the first to omit any clinic visits or clinic tests that are usually required, and to assess whether prospective patients are within the 10-week gestational limit for medication abortion, we're going to do something very revolutionary. We're going to actually believe people when they say that they're certain of when their last menstrual period is and calculate a date based on that. And so, yeah, it is unbelievable how just crazy an idea is like that in the current institutions of clinical research that we work under.
I want to thank you for shouting out the pharmacists, because I also want to include them in our group of people as we think about education and training and care provision. So thank you for that. You mentioned telemedicine. And would you sort of walk us through briefly, what are the major barriers to why we haven't seen an expansion in telemedicine?
Yeah, that's a great question, and currently my favorite topic. First, we need high-quality clinical trials demonstrating that telemedicine is safe and effective. So this would be, a telemedicine model. A clinician can join and communicate with a patient in the comfort of their own home over video chat, and then mail the pills. And then another barrier are 19 states currently have laws against telemedicine. They're telemedicine bans in various...
Specific to abortion?
Yes, sorry, thank you. Yes, they promote, they love, it's often rural states love telemedicine because it is so effective in bringing primary care to patients. However, they carve out abortion and say that it can't be used for telemedicine.
And we've heard one comment or a couple comments around self-managed abortion. So, can you talk a little bit about, what your thoughts are in terms of mifepristone and misoprostol use in our current environment?
Sure. So we know that it's happening. In the Google AdWords study I mentioned, 5% of those the 50% who obtained an abortion reported that they had their abortion by buying pills online. So we do know that it is happening, and it will be very hard to study. Say in a post-Roe scenario, how will we know who's having abortions? What are the numbers? So we won't see rows of people in hospital beds like in the 60s. So we will need to be creative. We need to look at Google searches for self-managed abortion and look at that, look at changes over time. We could try to monitor sales of pills, purchasing pills over the internet, maybe try to access some of these companies if possible. And then we might be able to monitor change over time as abortion-related emergency departments visits increase. We know that 1/100th of all emergency department visits among women of reproductive age are abortion. 1/100th of all emergency departments visits right now are abortion-related, and we could look at change over time. Not that self-managed abortion is dangerous, but often people will go to seek care, reassurance, ask about those symptoms at an emergency department because that's often the primary source of care for many people. And then what we could also do is maybe a series of cross-sectional population-based surveys asking about people's experiences of self-managed abortion. And then there's always statistical modeling and projection. So Kirsten Thompson at the Bixby Center is working with Diana Green Foster and myself, and we're working on analyses modeling the distances that people travel to obtain an abortion and modeling what will happen if Roe were to fall or bans were to go into effect over time and at different scenarios. So there's lots to be studied as access declines.
Awesome. Before we open it up to audience questions or Slido questions, is there anything else that's burning that you think you might want to say that you haven't said yet?
Eleanor.
Could I have the people from Access stand up again? I just want to say again, I mean, this is not, I mean...
Oh, there we go. Please do meet these people and volunteer and make these connections. This is what we're going to need. They make things happen. They make things happen. So please meet them, work with them, learn from the people they take care of, and help them. There is another group I want to mention, which is All Options Pregnancy Resource Center. They are also Indiana and Oakland based, and they do train people from around the country to help anyone who has questions about pregnancy care, pregnancy decision-making, post-pregnancy parenting. And they also are another place where they serve as a very important resource, and you could be trained by them. They're training people this fall. So all options and access and yes.
Thank you. Jason, do we have questions?
We do. First question, of the clinical workforce and training topics discussed, what would you say California specifically needs to prioritize?
On training topics?
Yeah, clinical workforce and training topics.
In California. Everything I described. California specifically. I think everything I described. I don't know what people really... There might be something else. Do you have any thoughts about that?
I do. So I'm going from moderator to participant.
Yeah.
Because I think that's important. One of the other people that I'll be talking with when I get to A1 is Dr. Lisa Wolf, who's a nurse with a PhD, and she is currently the research director for the Emergency Nurses Association. Mm-hmm. And one of the things that we really want to get at is something that Eleanor said. What is respectful care? What is understanding the fundamental components that any clinician would need to know in terms of reaffirming, like you said, Ushma, normal trajectory of either a medication abortion or post-abortion care from aspiration or from induction. So really not having people, because of their lack of educational exposure, inappropriately manage or take care of an individual who had an abortion. So really increasing their knowledge and their educational exposure to make sure that emergency department staff and clinicians have an evidence-based understanding of how to take care of people who might present in those different environments.
Can I have one other group stand up?
Yeah.
The nurses, counselors, and doctors in the room who work at the Women's Option Center, either at San Francisco General or at Mount Zion. Okay, residents.
I do have one thought about just one thing I didn't mention about training, which is that, again, focusing on doctors and nurses, we are bound by codes of professionalism and ethics. Mm-hmm. And we are bound to promote patient autonomy. We are bound to put the patient before ourselves. And we are bound to promote social justice. And I just want to remind us all of that as we go forward for all of these disciplines and specialties, that this is really the code and this is the framework we need to sort of use for all of our training efforts.
Great, so we're running up against time, so we'll just have one last question, if that seems okay. We're right at 7, unless we want to run. Okay. So we've talked about patients having access to info about abortions, but how can we ensure they discover the correct information, i.e. misleading Facebook or Google ads?
Go to their websites.
Yeah, there are. Yeah, hopefully people will be. Google just has this new policy where they are requiring abortion providers to testify. I don't know exactly how they're going to verify the accuracy of the clinic responses, but they must respond, do you provide abortions, yes, no, when they advertise. And so hopefully there could be, we could, in time, there could be a way that evidence-based sites would be verifiable in some way.
I mean, what I've said, which is kind of the opposite of this question, which is that, now, unfortunately, whereas there used to be and still are, not outside of our hospital, but outside of many places that provide abortion, the people with the awful signs and the misinformation and the abuse. And now with the internet, we've invited all of those people onto our phones and in our homes. And so patients come to us. They have effectively been, just like the level of abuse they've gotten and the judgment they put on themselves is in part because of the shit that has gone to their homes and their phones, and it's just really, really disturbing.
Well, I think one of the things that we actually need is public service announcements, and I know I'm biased in this because, I think billboards are a really good thing.
We have no
but I also think that public scholarship and really leveraging the currency that we have, even just lifting our own self-imposed social media ban, I think is really important so that people know that there are opportunities and there are people who are having conversations. I also think lifting up the work of abortion storytellers and other providers who are really more public in their work to really make sure that as we are trying to get fact-based and evidence-based information to individuals, that we are using reputable sources. So even within your own circles, if people are sharing misinformation, it's very helpful when we can correct them.
And the Bixby Center site is a very evidence-based.
And can I just say, in front of my mother and my department chair, I'm so sorry for my use of bad language.
And I would like to thank Erin Grant because they reminded me that we should have comprehensive sexual education.
Yeah, of course.
So I would like to please call the chair of the OBGYN department, Dr. Amy Murtha, up to the stage.
Yeah.
She will provide us some closing comments, please.
I'll make my remarks brief, but I first wanted to just thank all of you for being here and for participating in such a wonderful way. Thanks to Bixby, to ANSIRH, to all those that put this together, pulled this off. Thanks to our panel speakers. It really has been just an inspirational evening. I'm honored to be here tonight and to have the opportunity to participate in such an important conversation in a critical time in our country. As the chair of the Department of OBGYN and Reproductive Sciences at UCSF, I've had an incredible opportunity to witness firsthand what advocacy and commitment can accomplish. I've come to expect the impossible at UCSF. A commitment to reproductive rights and reproductive justice is a critical piece of what we do at UCSF and in the Department of OBGYN, and I'm proud to serve as the chair of this important department. We have so much to contribute, and it's really an honor to be here. I came from North Carolina, a somewhat more restrictive state. And it's been an interesting experience for me to practice in this state, actually, and to be able to share my experiences from North Carolina, which were quite different. So today's times are really tumultuous, and our ability to control and influence access to full-service reproductive care continues to be threatened. What I heard tonight reflected in your voices is the urgent need for action. And I would say that need is actually something that's been long-standing, as was suggested by some of our panel speakers. So what can we do? Partnering with our local, state, national organizations, partnering with the people that Eleanor just kept making them stand up and down and up and down. The poor we can make them stand again if you want, Eleanor. But looking for ways to elevate our voices is critical. I think there were a couple of points that I wanted to just sort of elevate again one more time. And one actually is one that the department is really focused on quite a bit right now, and it's health equity, structural racism, and how social determinants of disease impact health outcomes, but really also access to care. And addressing that and taking that on, while it's a huge challenge, is something that's absolutely necessary if we are to be effective. And I wanted to just mention that again. Of course, being a department chair in an academic institution, focus on research is another way that I think we can really contribute to the conversation, and certainly with education and our advocacy work as well, and our newly formed advocacy strategic planning group led by Dr. Dan Grossman. This is a long-standing battle, and as I considered what it was that I wanted to share with you tonight, I started thinking about my kids and my teenagers. I have a 15 and a 16-year-old, and I thought, gosh, this is really a generational issue, right? But it really isn't, actually. And I kept trying to make it a generational issue and create a story that fit that model, but it really isn't. It's the same struggle that we've been talking about for a really long time, and it's an intense moment in time, but it is the same story. So I decided I was going to ask my kids. I have to give the closing remarks at this really important event. What am I going to say? Like, these people that are speaking are national experts. How can I contribute to the conversation? So they taught me about Roe v. Wade and told me about how it was really based on privacy, the original decision, and how it's become more equity, and they carried on and on and on. And I for some reason, my 15-year-old decided it was time to get Dad involved in the conversation, who was in another room, who yelled, "Dad, are you pro-life or pro-choice?" Which I don't really like those terms, but he said, "What?" And she said, "Are you pro-life or pro-choice?" And so he paused for a moment and he said, and this is a very wise man. He's the husband of an OBGYN chair with 2 teenage daughters. And he said, women should get what they want. I'm reading because I want to make sure I get it right. When they want, anytime they want. And he is smart. That was the right thing to say to his wife and 2 teenage daughters. But I think it actually just, again, it was a fun time. My teenage daughters really enjoyed that answer. But it does actually, I think, reflect that culture that we really should be able to do with our bodies what it is that we want to do. And have that choice. And so I, again, want to thank you all for being here tonight. It's really been a wonderful evening. And now, actually, it's time for you to get up and enjoy some refreshments.